In this section, we are going to look at the principles that govern respiratory gas exchange and the mechanics of pulmonary ventilation. Pulmonary ventilation is the physical movement of air into and out of the respiratory tract, its primary function to maintain adequate alveolar ventilation. A single respiratory cycle consists of one inspiration and one expiration, involving the expansion and the contraction of the thoracic cage to produce airflow into and out of the lungs. Ventilation provides a continuous supply of oxygen required to meet metabolic demand and prevents the buildup of carbon dioxide. Exchange of oxygen and carbon dioxide between the body's interstitial fluids and the external environment is called external respiration and occurs in the lungs. Internal respiration is the exchange between blood and cells, the absorption of oxygen and the release of carbon dioxide. Understanding pulmonary ventilation, the transport of gases in the blood, and the exchange of gases with the tissues requires an understanding of certain gas laws of physics. 1. Boyle's law. The pressure of a given quantity of gas is inversely proportional to its volume. 2. Charles' law. The volume of a given quantity of gas is directly proportional to its absolute temperature. 3. Dalton's law. The total pressure of a gas mixture is equal to the sum of the partial pressures of its individual gases. And 4. Henry's law. At the air-water interface, the amount of gas that dissolves in water is determined by its solubility in water and its partial pressure in the air. As you can see, the diaphragm forms the floor of the thoracic cage, separating the thoracic cavity and the abdominal cavity. The relaxed diaphragm possessing the shape of a dome that projects superiorly into the thoracic cavity. Boyle's law explains the relationship between volume and air pressure. An increase in the volume of a container lowers the pressure of the air inside. A decrease in the volume raises pressure in the reduced space. Air flowing from an area of high pressure to an area of low pressure provides the basis for pulmonary ventilation. Therefore, to allow respiration, we have to cycle between increasing and decreasing the volume of the thoracic cage. To understand the mechanics of respiration and the principles of gas exchange, we must know the pressures inside and outside the respiratory tract, with millimeters of mercury commonly used to report both gas pressure and blood pressure. At the start of each breath, pressures inside and outside the thoracic cavity are identical, with the interpulmonary and atmospheric pressures equal at 760 millimeters of mercury. Therefore, no air moves into or out of the lungs. Inhalation itself is an active process, involving one or more of the following actions. Contraction of the diaphragm flattens the floor of the thoracic cavity, increasing its volume and drawing air into the lungs. At rest, this brings in roughly 75% of the air during normal breathing. Contraction of the external intercostal muscles assists in inhalation by raising the ribs and sternum like a bucket handle upwards. Due to the nature of the articulations between the ribs and the vertebrae, superior movement of the rib cage increases the depth and width of the thoracic cavity, increasing its volume. This action contributes roughly 25% of the volume of the air into the lungs at rest. Increasing the volume of the thoracic cavity that expands laterally, vertically, and anteriorly causes a decrease in the internal pressure, known as the interpulmonary pressure of the lungs. This decrease creates a pressure gradient as interpulmonary pressure drops to -3 millimeters of mercury below atmospheric pressure, causing air to flow into the lungs. The pressure gradient 760 millimeters of mercury in the atmosphere to 757 millimeters of mercury in the alveoli to allow air to enter. Air continues to enter the lungs until their volume stops increasing and the inflowing air quickly achieves an interpulmonary pressure equal to atmospheric pressure outside at 760 millimeters of mercury. Conversely, if the lung volume decreases, interpulmonary pressure rises above atmospheric pressure and air flows out of the lungs, again down a concentration gradient. Expiration is predominantly a passive process as the inspiratory muscles relax, the diaphragm returns upwards, and the inferior movement of the ribs and sternum like a bucket handle decreases the depth and width of the thoracic cavity, causing it to contract in all three directions, reducing its volume. Interpulmonary pressure rising to be +3 millimeters of mercury above atmospheric pressure, and therefore air flows out of the lungs. At the end of exhalation, air again stops moving when the difference between interpulmonary pressure and atmospheric pressure has been eliminated. Exhalation is usually passive but can also be active, depending on the level of respiratory activity. At rest, air is exhaled passively by the relaxation of inhalation muscles, allowing the elastic recoil of the thoracic cage to return to normal, whilst in active exhalation, accessory muscles aid in the expulsion of air. During active inhalation, contraction of the accessory muscles, the sternocleidomastoid, serratus anterior, pectoralis minor, and scalene muscles, assist the external intercostal muscles in elevating the ribs. This increases the speed and amount of rib movement, increasing lung volume further. During exhalation, the internal intercostal and transversus thoracic muscles can actively depress the ribs. This action reduces the width and depth of the thoracic cavity. The abdominal muscles, including the external internal obliques, transversus abdominis, and rectus abdominis, assist by compressing the abdomen. This action forces the diaphragm upwards. The size of the pressure gradient increases when you breathe heavily. At maximum capacity, the pressure differentials can reach minus 30 mm of mercury during inhalation and plus 100 mm of mercury during exhalation in a trained athlete. Muscle contraction is not the only force that expands the lungs. Another is the warming of inhaled air. Charles Lowell states that the volume of a given quantity of gas is directly proportional to its absolute temperature. Inhaled air is warmed to 37 degrees by the time it reaches the alveoli. This means that on a cool day, when the outdoor temperature is approximately 16 degrees, the air temperature will increase by 21 degrees during inspiration. An inhaled volume of 50 milliliters will expand to 536 milliliters, and this thermal expansion will contribute to the inflation of the lungs. Dalton's law explains that the pressure exerted by each gas is independent, the collective pressure of these gases giving the total pressure of 760 millimeters of mercury in the atmosphere. For example, oxygen entering the lungs has a partial pressure of 40 millimeters of mercury, and after exchange a partial pressure of 95 millimeters of mercury, whilst carbon dioxide entering the lungs has a partial pressure of 46 millimeters of mercury, and after exchange a partial pressure of 40 millimeters of mercury when leaving in expiration. Henry's law relates directly to the exchange of gases within the alveoli. Oxygen is able to move from air into the blood and carbon dioxide from the blood into the air due to the exchange of gases permitted by the cycling of air induced by pulmonary ventilation, changing the pressure and maintaining concentration gradients. Respiratory airflow is governed by the principles of flow, pressure, and resistance. The flow is directly proportional to the pressure difference between 2 points and inversely proportional to resistance. Therefore, the greater the resistance, the slower the flow, which in turn causes a slower rate of diffusion. Airflow resistance being governed by 3 particular factors: 1. The diameter of the bronchioles, 2. Pulmonary compliance, and 3. Surface tension of the alveoli and distal bronchioles. For further information, see the in-depth section.